First of all, I'd like to thank the organizers for inviting me. It's really a great pleasure to be here. And I've really enjoyed the talk so far. I'm going to present some work that is still in progress, so please bear with me. I'm going to argue for an approach to clinical innovation and unproven methods that's protective or cautious, focuses on protecting patients. Well, the case of Macchiarini, the Macchiarini case that was mentioned here earlier, is part of the motivation behind my approach, and I'm not going to talk about it in any detail, but it is in the background, even if right, it's in background here. So what I'm thinking about when I talk about clinical innovation or unproven methods, things like this, medical interventions that deviate significantly from standard medical practice, that are typically not there's no proven method available and typically applied as a last resort, and where the primary purpose is to benefit the patient, to save life or alleviate suffering. And in the case of Macchiarini, this aim sort of got mixed up, but maybe we can discuss that later. In any case, I think it is safe to say that the traditional approach to clinical innovation outside of clinical research has been rather permissive. It's been left to the clinical judgment of the physician to offer a patient the option of an unproven treatment, and to the judgment of the patient whether to take the offer or not, to give or withhold consent. Of course, in some cases, the patient is not even asked, especially when you go a bit back in history. In any case, the permissive approach has been based on the framework of clinical practice. And I think this has been changing in recent years, partly because of various controversies and medical scandals. And some have even argued that experimental treatment should only be offered in the context of clinical research, where the patient is protected as a research subject. Now, this discussion is sometimes framed in terms of the distinction between therapy or clinical practice on the one hand and the research on the other. Now, since clinical innovation is sometimes seen as either blurring the line between therapy and research or occupying an area where therapy and research overlap, or maybe in some gray area between them. Let me therefore first say a few things about the research-therapy distinction. Right. It's not difficult to make a conceptual distinction between research and therapy in terms of the respective aims. The primary aim of research is to produce generalizable knowledge, while the primary aim of therapy is enhancing the health or well-being of an individual patient. So, in what sense does the line of this distinction get blurred? In a Belmont report, the American Belmont report was a report that was taken up as research ethics policy in the United States in 1978, if I remember correctly. And the report starts out with discussing the distinction between research and therapy, and in what sense that distinction might get blurred. And to quote the report, the distinction between research and practice is blurred partly because both often occur together, as in research designed to evaluate therapy, and partly because notable departures from standard practice are often called experimental, when the terms experimental and research are not carefully defined. The report goes on to say that clinical innovation is not automatically research. As Gert Helgeson has pointed out in a recent article, it is usually not difficult to differentiate between practices that are part of research and practices that are part of clinical care, even if they are conducted on the same patient almost at the same time. If the primary aim is to benefit the patient, the data is collected for the purpose of publishing a research article on the experimental treatment and its outcomes, it is arguably still clinical research, clinical practice and not research. So, but does clinical innovation have to be one or the other? Does it have to fall under research or clinical practice? I think maybe this is a false dichotomy. Why not consider clinical innovation as a distinct activity? It is like clinical practice in that the primary aim is to benefit, or should be, to benefit the patient, but it involves experimenting on a patient. It requires that the outcomes are registered and shared, and preferably in research publications. Now, one might argue that publishing the outcomes of experimental treatment adds little to the risks for the patient, and it therefore does not justify additional ethical oversight on top of that required by clinical practice. So, following Paul McNeil, I want to stress that the use of unproven methods on a patient, it is an experiment. One is experimenting with a patient. Even if it is not the research, it involves subjecting a patient to an experiment where the benefit and possible harms are usually very, very uncertain. For the need for ethical oversight and regulation, it is not a deciding factor whether clinical innovation is more like research or more like clinical practice. The deciding factor is the experimental nature of the treatment and the potential for harm. And here I think I agree to some extent with Jonathan Ives about the risks and the potential harms being crucial. So therefore, I would suggest that clinical innovation be regulated according to the potential for harm, not by forcing it into either clinical context or research context. All right, so now to what I'm calling the permissive approach. According to this approach, clinical innovation is therapy. According to this approach, clinical innovation is therapy and not research. Therefore, it should be regulated like clinical practice and not like research. The World Medical Association's Declaration of Helsinki provides, I think, an example of a relatively permissive view of clinical innovation. And to quote, in the treatment of an individual patient where proven interventions do not exist or other known interventions have been ineffective, the physician, after seeking expert advice with informed consent from a patient or a legally authorized representative, may use an unproven intervention if, in the physician's judgment, it offers hope of saving life, reestablishing health, or alleviating suffering. This intervention should subsequently be made the object of research designed to evaluate its safety and efficacy. In all cases, new information must be recorded and, where appropriate, made publicly available. So here, the determining factor for the acceptability of an unproven method is that, in the physician's judgment, it offers hope of saving life, or reestablishing health, or alleviating suffering. So, I think the main ethical concern here is the autonomy of the patient to request and consent to an unproven treatment, as well as the autonomy of the clinician to exercise her or his judgment in deciding whether an experiment, whether an experimental treatment is appropriate for the patient. It seems callous to deny a patient in desperate circumstances perhaps the only hope of survival or regained health. Regulations should not prevent patients' timely access to potentially life-saving unproven methods, nor limit physicians' clinical freedom under this permissive view. So there are, I think, some significant problems with this permissive approach, and I think many of those issues have come up in the talks today. So first, there is, in many cases, in many cases of clinical innovation, a considerable element of uncertainty about efficacy and safety, as you have heard. Sometimes it's even greater than first in humans research. If the treatment has not been subjected to a clinical trial, there will be no data at all about safety and efficacy of the treatment in humans. If the treatment has not been subjected to preclinical testing, especially if it has not been tested in appropriate animal models, its use is barely defensible. And that's one of the issues that came up in the Macchiarini case. Right. Right, so the potential for harm, I think, in clinical innovation is therefore no less than the potential for harm in clinical research. In some cases, where there is evidence available about efficacy and safety, the likelihood of benefit may be very low, and the likelihood of significant additional suffering actually quite high, in particular at the end of life. This is not only because of lack of evidence for efficacy and safety, but also because of patients' comorbidities. Even if the treatment is successful, the patient might not survive for long for various different reasons. Some have even suggested that the success of clinical innovation should not be measured by the outcome for the patients when the patients are very sick or dying, but by its use for science. But in that case, it seems the primary aim is no longer the benefit of the patient, but the potential for producing knowledge. And this is actually an argument that Macchiarini made in a paper on the ethics of tissue engineering, where he was a corresponding author. Right. So in any case, the potential harm involved is one issue. The ability of the involved persons to evaluate the harm is another one. The clinician may be too optimistic about the potential benefits of an experimental treatment and the risks. Paul McNeill offers a very illustrative example from the early days of heart transplantation. In 1967, South African surgeon Christian Barnard replaced the deceased heart of a 55-year-old grocer, Louis Oskansky, with the healthy heart of a young woman who had been struck by a car and suffered fatal brain injuries. Prior to the operation, Barnard gave Oskansky an unfounded and misleading assurance that he had an 80% chance. Oskansky survived in very poor condition, and in spite of persistent efforts by Barnard, including massive doses of anti-rejection drugs, his new heart failed 18 days after surgery. So previous experiments on dogs had been unsuccessful, with the dog surviving only days. Yet Barnard justified his experiment with a claim that it gave the patient a chance he begged for, actually, because it was really his only chance at survival. But again, Barnard suggests that there was an 80% chance of success. So just as an illustration of potential clinician bias and possibly conflicts of interest. So clinician bias in such circumstances is quite well documented, and it can also be fueled by conflicts of interest when a clinician has an invested interest in the treatment or the innovation. Right. Now the patient may suffer from similarly from a bias. In clinical research, patients sometimes expect a therapeutic benefit when no such benefit should be expected. This has been called the therapeutic misconception. Researchers may find it difficult to explain to patients, especially very sick patients, that no therapeutic benefits should be expected from participating in clinical research. In some cases, researchers have even encouraged patients' therapeutic misconception in order to secure their recruitment. In the case of clinical innovation, the primary aim should be to benefit the patient. There should therefore be some expectation of a therapeutic benefit, but it may in a similar manner be overinflated, or the expectations of the patients may be unjustifiably high. In addition to the problem of potential bias, the patient is often in a desperate situation, as you heard, especially when no standard treatment is available and the patient is very sick or even dying. A patient in this position may be vulnerable and inclined to take any possible hope that is offered. So this invites a considerable potential for exploitation. A clinician who is eager to try out an experimental treatment, which may bring her or him fame and fortune, might see a dying patient desperate for a slightest chance as a sort of a win-win situation. The clinician gets an opportunity to experiment with a new treatment and the patient gets at least some hope, unfounded as it may be. In the worst case, a clinician might treat clinical innovation as a possibility of experimenting on patients while avoiding ethical oversight. So there are no research protocols, no research ethics committees, no proper informed consent procedures, and so on. It's only the clinician and the patient. However, clinical innovation is regulated. I think it must not be a loophole for researchers looking to avoid ethical oversight. So coming to my suggestion for a more protective, a more cautious approach. In light of these problems, I would like to propose a protective approach based on three pillars or three aspects. The first is a detailed, written, informed consent and an informed consent procedure, much like what is required for research participation. It must be made clear that the treatment is experimental and what evidence there is for both safety and efficacy, as well as other things like the qualifications of the clinicians involved. The second pillar is independent review. A research ethics committee is well placed to conduct such a review, but I could also imagine a specific committee established for this purpose. The main difference from regular research ethics applications is that there may barely be a research protocol at all, or at least there are different requirements for the research methodological aspects of it. But of course that will depend on each individual case. And if it is possible to do the or to use the employment methods in the context of research, of course that should be then done, or that should be decided by a research committee as well. In any case, independent review does not have to be too much of a burden or impede access to innovative treatments for patients in desperate need. It has to be flexible with regard to the potential harm and the urgency involved. For example, there could be expedited approval in urgent cases and the possibility of retrospective review in emergencies. If the risks are minimal or it is not clear whether treatment deviates enough from a standard practice to count as experimental or innovative, something like a chair's approval might be appropriate. Finally, a third pillar is the regulation itself. Producing regulation aiming to protect patients while promoting clinical innovation is not enough. Implementation must be robust and the ethical oversight mechanisms must function and be meaningful. And a part of the reason for this is that when there are clinicians involved who don't have much respect for regulations, who are intent on scientific misconduct, this is the mechanism that might be able to catch them before greater harm is done. But for that to happen, these ethical oversight mechanisms have to function. So in conclusion, I have suggested that clinical innovation should be regulated as a distinct activity alongside research and clinical practice, with a focus on the potential for harm or the risks, and for protecting patients. Proper informed consent is essential, but respect for autonomy of both clinician and patient should not carry most of the moral weight. Because of the potential for harm, for bias, and for conflicts of interest, and for exploitation, the autonomy and freedom of the patient and the clinician and the moral character of the physician should not be essential or sort of the carrier of the ethical regulation of the practice. Independent review must be performed either by a research ethics committee or other competent and independent institutional body. This can be done without impeding access to clinical innovation or placing unreasonable burdens on clinicians. And finally, regulation must be robustly implemented and provide meaningful oversight. So that was my suggestion. Thank you very much for your attention.
Yeah, thank you for a great and very interesting presentation. I have a question regarding your suggestion to have a retrospective review in emergency cases. What would be the function of that retrospective review, and what would be the legal consequences of it?
No, I think this. I think there may be cases, perhaps in innovative surgery or in emergency rooms, where decisions have to be made very quickly, and even for doing something that is not a matter of standard practice.
Yeah.
And I think it's important to have that then reviewed afterwards, to see, at least to learn from it and see if things could have been done better or differently. So that doesn't, that can't replace proper independent review, but I think it is the best solution for that emergency case.
And if it's not good conducted in a good way, would any legal consequences follow, or would it just be a review to learn for the future?
Right. I think it depends very much on the case. I mean, there could be cases where it's just a matter of medical misconduct, which I think would rarely be the case. But when there is really a matter of doubt, a matter of uncertainty, I think it's a rather a question of learning from it.
Yeah. Thank you.